Neurocognitive Disorders, Topic 3, Differentiating Delirium from Dementia. Dr. Sara Gleason, Department of Psychiatry and Human Behavior. In previous modules, we examined the DSM-5 diagnoses of delirium and major and mild neurocognitive disorders. Recall that the term dementia correlates with the DSM-5 diagnosis of major neurocognitive disorder. For purposes of this module, we will take the liberty of using dementia to overlap with the major and mild neurocognitive disorders. So our goal will be to distinguish delirium from dementia, inclusive of major and mild neurocognitive disorders. To review, delirium is a disturbance in attention and awareness. It develops over a short period of time and is a change from baseline and tends to fluctuate in severity. There is disturbance in cognition. The above changes are not better explained by an existing neurocognitive disorder. There is evidence that the disturbance is a consequence of a medical condition, intoxication, or withdrawal. Recall that we think of delirium as a temporary state, which with proper supportive care or other intervention will eventually resolve. Mild neurocognitive disorder gives evidence of modest cognitive decline that is more enduring. It is from a decline from a previous level of performance in one or more cognitive domains. It does not interfere with capacity for independence, unlike major neurocognitive disorder. The cognitive deficits of a mild neurocognitive disorder do not occur exclusively in the context of a delirium, although a person with a mild neurocognitive disorder can have a superimposed delirium. The cognitive deficits of a mild neurocognitive disorder are not better explained by another mental disorder, such as depression or schizophrenia. Major neurocognitive disorder gives evidence of significant cognitive decline from a previous level of performance. The deficits interfere with independence in everyday activities. The deficits do not occur exclusively in the context of a delirium, although a delirium can be superimposed on an established major neurocognitive disorder diagnosis. The cognitive deficits are not better explained by another mental disorder. To further complicate matters, there are behavioral specifiers for major and mild neurocognitive disorders that include with or without behavioral disturbance. Of course, it is the cases of behavioral disturbance that often come to clinical attention. In the case of a major or mild neurocognitive disorder with behavioral disturbance, we might see psychotic symptoms, mood disturbance, agitation, apathy, or other behavioral symptoms. This can make it challenging for us to parse out which is due to delirium versus a connected component of the neurocognitive disorder. This chart highlights some of the general differences between delirium and a dementia or neurocognitive disorder. The onset of delirium is generally acute. With dementia or neurocognitive disorder, we see an insidious or slow onset. Sensorium of an individual with delirium is fluctuating, whereas it can be clear in the individual with dementia or neurocognitive disorder. Mood is often apprehensive in someone with delirium, whereas we may not see an affected mood state in a person with dementia. Memory, often globally impaired in delirium. In dementia or neurocognitive disorder, we may see focused impairments in recent or remote memory, depending upon the nature of the dementia. Attention and orientation are markedly impaired in delirium. Recall that that is the hallmark of delirium. Whereas we may only see mild to moderate impairment in attention and orientation in the case of someone with a dementia or neurocognitive disorder. Finally, the etiology and course of a delirium are considered reversible with appropriate supportive care and treatment of underlying conditions. In the case of a dementia or neurocognitive disorder, with rare exceptions, we generally see an irreversible and progressive course. I encourage you to look at the Osmosis, Dementia, and Delirium clinical practice module. It is a good discussion of the dementia versus delirium features, and I think will be helpful for you, not only for test-taking purposes, but for your clinical practice.